was hard for us to get our stain in there because it was resistant to that as well. And its growth, or its arrangement, so to speak, is a rope-like growth because of that waxy component in the cell wall, and that's called the Ford factor. And Mycobacterium tuberculosis was first isolated by Robert Koch in the 1800s. He was a contemporary of Pasteur, and remember, Pasteur never was able to say this bacteria causes this disease. He knew bacteria caused disease. He just didn't know which bacteria caused which disease. But Robert Koch not only identified this Mycobacterium tuberculosis, he was the one that also worked with anthrax. So here's a picture of that Mycobacterium tuberculosis. It looks just like your control. What is the primary stain in the acid fast? Carbofuchsin, and it is that kind of reddish color that we see there. And the growth is, they grow kind of like in a stick together, and they call that a corded growth, where those little individual bacteria are sticking together because they have that sticky wax stuff in their cell wall. Transmission is by respiratory aerosol. The bacteria gets inhaled, and then once it's in your lungs, they are phagocytized by your phagocytic cells, your macrophages. And if you are healthy, then your macrophages are able to destroy that bacteria. If the infection goes past that stage, then the host will isolate the bacteria in a walled-off lesion called a tubercle or granuloma. And if the disease stops at this point, then those lesions will slowly heal and they become calcified. And so if you take an x-ray of somebody with these lesions in their lung, it will appear as what you can see them, and they call them Gong complexes on x-ray. If the host defenses fail at this stage and that tubercle breaks down, then the bacteria are released into the lungs. And from the lungs then, they can get into the cardiovascular and the lymphatic system. You can get what's called disseminated infection. It's also known as miliary tuberculosis, and it overwhelms the body's defenses. So this is when those tubercles break down and they start going throughout your lungs. Symptoms are weight loss, coughing up blood, because you're coughing so much you have damage to your tissues, and you just don't feel well.
I feel you on my head. What? Oh.
At one time, they used to call tuberculosis consumption. And I used to read novels, and I read about this consumption. I didn't know what consumption was. But back in the turn of the century, there were a lot of cases of tuberculosis. I had a great aunt that came down with tuberculosis, and at that time, like at the early, like maybe 1900s, or they used to put them in sanitariums to get well. Now, though, they treat them with drugs. There's about 10 drugs available, and these drugs, though, must be taken for a long period of time, between 6 and 9 months. We have to have a prolonged treatment like that because the bacteria grows slowly, or it's dormant. So most antibiotics don't work against the growing bacteria. And they may be hidden in the macrophages. And if you have a bacteria that is living in the macrophages, well, then that macrophage is protecting it from antibiotics. in your immune system. There's a vaccine for it. It's an attenuated vaccine of Mycobacterium bovis, and that's one that normally would affect cows. Here's a picture of a normal x-ray of lung. When you see a lung x-ray, you want to see dark, empty space. So that's a normal one. And this is showing you the tubercles or granulomas in the lung. And now this is a picture of somebody that has familiary tuberculosis in the lung. And you can see that is lots of spreading out there into the lungs as opposed to, oops, going the wrong way. As opposed to that one. You can see how nice and clear those lungs are. They have a skin test to check for tuberculosis. It is purified proteins from the bacteria that are injected beneath your skin. And you get that, and then you have to come back in 24 or 48 hours to have it read. And a positive reaction is like redness and hardening around the injection site. A positive test, though, does not necessarily mean that you have an active case of the disease. So in young children, a positive reaction is a probable active case, but in an older individual, it could be that they've had a previous infection or a vaccination, and they don't necessarily have an active case. Pneumonia also affects the lower respiratory tract. It's a microbial disease of the bronchial tubes and lungs. And there's many different organisms that cause pneumonia. You can have a bacterial or a viral or a fungus can also cause it. And the symptoms, the common symptoms start with like a upper respiratory tract symptoms of a runny nose or congestion. That is common. Get fever and then the onset of lung symptoms. And lung symptoms are chest pain, fever, cough, production of a discolored sputum, rapid and labored breathing. The severity and the spread of and speed of the onset of symptoms varies with which type of pathogen is causing the pneumonia. So pneumococcal pneumonia is also known as lobar pneumonia. It usually develops in people who are already ill. The pathogen is Streptococcus pneumoniae. Causes 2/3 of cases of the pneumonia. And so therefore, since it causes most of the pneumonia, it's called typical pneumonia. This pathogen also causes middle ear infection, meningitis, and sepsis. The Streptococcus pneumoniae has a capsule. So that's a virulence factor for the bacteria. It makes it resistant to phagocytosis by your immune cells. This particular pathogen can be differentiated into 90 different serotypes, and 23 of these cause disease in humans. And so those 23 are used in a vaccine for this particular type of pneumonia. It involves the bronchi and alveoli. So the alveoli fill with red blood cells and neutrophils and fluid. And then it's the fluid that interferes with the uptake of the oxygen. And one way that they diagnose pneumonia, because of the fluid, is they take an x-ray and they look for a fluid line. Sputum for pneumococcal pneumonia is rust colored from blood that gets coughed up. The pneumococci can invade the bloodstream, the pleural cavity, and the meninges. Symptoms are a high fever, chest pain, a persistent cough, that rust-colored sputum, increased pulse, and difficulty breathing. In the elderly, there's a 20% mortality rate. And the initial diagnosis is made by that x-ray looking for that fluid line. I think this is the one that they have a vaccine that they're trying to get all the older people. Laboratory diagnosis is by isolation and identification, and it's based on, if you're gonna put it on blood agar, this streptococci is alpha hemolytic on blood agar, as opposed to Streptococcus pyogenes. That's the one that is what on base, and that particular bacteria causes a lot of different things. They also can run this option disc test or a vial solubility test and other types of serological tests checking for antigens and antibodies against those antigens. Treatment is penicillin, and for this bacteria, antibiotic resistance has been increasing. There's a purified capsular vaccine, and that contains capsular material from those 23 serotypes. Primary atypical pneumonia, the one that they commonly call walking pneumonia, that's caused by Mycoplasma pneumoniae. And one thing that we know about Mycoplasma is it does not have a cell wall. So you can't do a gram stain on the bacteria because there's no cell wall to gram stain. And since there's no cell wall, then it is not sensitive to penicillin, so you wouldn't be able to prescribe penicillin to take care of it either. It's irregularly shaped small bacteria. And this type of pneumonia is common in children and teenagers, and it's rarely fatal. I had a son that had this. We went in and the doctor diagnosed him with pneumonia and prescribed probably penicillin. I can't remember now, but she called me later on because they used to actually grow these bacteria up on cultures, different types of media, and this was the bacteria he had, so she had to switch his type of antibiotic. Symptoms are a low-grade fever, a cough, headache, and symptoms can last for 3 weeks or longer. So even though you're sick, you're still up and around, but you know you're sick. And so they're calling, this one is called atypical as opposed to the one we just talked about, that's typical. Diagnosis, isolates from throat swabs, which most doctors don't do anymore, and sputum, and they grow it up on media that contains coarse serum and yeast extract. And it produces fried egg-looking colonies. Very, very small, so when you look at them, you have to be looking under a microscope for you to see them. You know how you can look at yours and see, you can see the colonies on them, and you put them under the dissecting scope to get your, what it really looks like, that you can at least see the colonies with your naked eye. They can also do PCR and serological tests. So treatment for this is tetracycline or erythromycin. So there's a picture of those little colonies. You can see they look like fried eggs. Legionellosis or Legionnaires' disease